Excellent. So thank you very much for the invitation. Daily awareness of pain in sexual relationships is truly moving. First time, well done. An amazing project and a very welcome and wonderful initiative. Glad to be here. I actually got to talk about a specific area, about something, a relatively narrow topic that discusses pain. First of all, pain in men is certainly, as Dr. Shashini mentioned in his lecture, much less common than pain in women. And within men, acute pain, that sharp pain, is far rarer than chronic pain. That's the main type of patients we see in the clinic. Those who complain of pain related to sex or sexual activity are people who suffer from chronic pain. The line here is fine. Often, sometimes it's acute pain, or acute pain that lasts for weeks, or even months. We'll discuss a few things today and to differentiate from chronic pain. In the case of acute pain, the pain is a warning sign. It's not part of the sexual experience. There's a conceptual difference in pain here, even before we get into the details. There is a little difference. In chronic pain, many times we tell patients, listen, there's chronic pain. We'll investigate your pain, check what we could do to help. You need to get used to, in some way, to living with it, easing it. But we don't. We don't expect a magic solution that will eliminate it completely. However, new pain is usually a problem of an acute, sharp illness. That requires treatment in some cases. Even immediate treatment, urgent treatment. Some of the images may not be suitable for children. So, if that bothers you, you probably shouldn't look at what we'll be talking about in the coming minutes. We'll be discussing pain originating from the skin of the penis, pain related to sexually transmitted diseases. We'll also be talking about skin problems that could be very disruptive to sexual relations and cause pain. We'll be discussing a condition called penile fracture, or a condition called Peyronie's disease. We'll be talking about Peyronie's disease, which causes pain. And we'll be talking about priapism, a painful erection that won't go away. We'll discuss all of these things in the coming minutes. And we'll be happy to answer any relevant questions afterward. A little bit of anatomy for those of us who aren't coming from a medical background, and certainly for the general public. So the penis is composed of 3 long cylinders. 3 corporate, 2 called corpus cavernosum. They fill with blood from both sides and responsible for erection. Then there's the corpus spongiosum. It contains the urethra, which also fills with blood during ejaculation. The corporates are covered. Those cylinders are encased in a tough sheath called the tunica, and when they fill with blood, we have an erection and sexual intercourse is possible. The tip of the penis is called the glans, or the head of the penis. This is the structure of the penis. Regarding diseases related to sexual contact, very briefly. In most cases, in most men, sexually transmitted infections manifest as urethritis. Urethritis manifests with symptoms related to urination. These symptoms are connected to the urinary tract. They are not related to sexual activity. They can be somewhat disruptive to sexual relations, but that is not the typical symptom that leads someone to seek treatment. Treatment with a doctor in classic urethritis, chlamydia, and gonorrhea are all examples. Other issues typically manifest as burning or pain during urination, but they're not related to sexual activity. In contrast, sexually transmitted diseases that cause sores on the penis can certainly be accompanied by pain. The pain is usually persistent and lasts for weeks or months until proper treatment is received. It indicates a condition that could be an infection. This condition requires treatment. There are also instances of localized eczema sensitivity. There can also be sensitivity to latex condoms. You should switch to a different type of condom. The treatment of topical steroids usually address this. Dermatologists typically handle it. And it's a relatively simple treatment. Regarding the lesions on the penis, you can see 3 examples here. These should only be considered for a superficial understanding. On the right, we have the classic pains by syphilis associated with penile disease. Generally, without pain, they're not accompanied by pain. However, they can sometimes be painful and very uncomfortable if they're the local infection. In contrast, the 2 diseases you see on the right are the monkeypox are very, very painful. And on the left, herpes. They are very painful diseases, especially during sexual intercourse. Sometimes that's how they manifest. Herpes is essentially blisters. At least it starts in the form of blisters that we all recognize. Herpes of the lips, and it's very painful. There's also neuropathic pain here. It's not just the blisters themselves, and they can also persist and become an open sore and a local infection. And that's something very painful. And on the right side, you can see has a stage of a blister that evolves to a lesion, a bumpy area under the skin, and then it becomes a severe ulcer. It's been chronic and very painful recently. There was a large outbreak of monkeypox in the country about 2 years ago, among the community of gay men, and a very small outbreak about 6 months ago. But for now, it seems to be under control. A large number of local men received the monkeypox vaccine. They also had sex with men. The monkeypox that has been brought into the country in recent years. And it seems that this problem is at least behind us, at least for the near future. It's a relatively rare disease in this country. Basically, it's an inflammation of the glans penis, known as balanitis, and of the coronal sulcus, and of the foreskin, which can be caused by various bacteria, various fungi. Treatment is usually topical, with steroids and the like, and it usually results from poor hygiene. It's not something that's common here. The more important issues I want to briefly address are circumcision problems. Phimosis means there's a problem. It means the foreskin cannot be retracted. Penis on the head of the penis. We have a situation where the foreskin is closed like a ring over the head of the penis. This is called paraphimosis. It's usually a chronic condition, and in paraphimosis, this ring descends beneath the skin, not beneath the foreskin. The foreskin swells. It's essentially an emergency situation that requires surgery. Otherwise, it essentially chokes the head of the penis. It causes very severe pain and swelling even to the point of necrosis of the penis head. So, a condition of the penis is a chronic condition. It sometimes requires surgery as well. Usually, it responds to local treatment. Paraphimosis is an emergency. It requires surgery because, essentially, we don't have good blood supply to the penis head. The penis head suffers greatly. Just to give you a brief overview, I don't have much time to talk about Peyronie's disease for just a few minutes. Peyronie's disease is a condition that many people are familiar with. Anyone who has encountered it won't ever forget it. Essentially, it's a disease of causes penile curvature. Penile curvature occurs in up to 3% of men. It usually occurs after the age of 50. It's more likely to occur in men with diabetes and men who have erectile dysfunction. It has an acute phase and a chronic phase. The chronic phase manifests into the curvature and in severe erectile dysfunction. But the acute pain that lasts for several weeks and months is a pain expressed through pain. And this pain is primarily during an erection, not just during sexual intercourse involving penetration, but during an erection in general. Sometimes it's the first symptom that leads the patient to see a doctor. The first symptom is almost always the curvature that appears. But the second symptom that leads the patient to a doctor is pain during sexual intercourse. And then we palpate this area, the local scar on the shaft of the penis. And the scar itself can be sensitive. But the pain isn't always characteristic of what appears during intercourse. It occurs during and with an erection, causing curvature and erectile dysfunction. The pain itself is characteristic of the acute stage. It usually subsides within a few months to a year, and almost always it resolves within a year and worsens in certain positions. It interferes with penetration and overall function. It causes depression. It's a truly terrible illness. There's also a great deal of shame associated with it. And there's a very significant connection between body and mind. It relates to erectile dysfunction, not just because of a local physiological problem, but also because of the impact on quality of life, self-image, body image, and so on. Peyronie's disease, treatment for it is very complex. It's complicated, so we won't go into it right now. There is medication available. There are injections for the plaques, an enzyme that breaks down the plaque or other medication. Options like Emgel involve a stretching device designed to provide relief. Surgery is also an option. However, the medication aspect for pain relief isn't entirely clear. It's likely that most people are given a long list of medications, typically for Peyronie's. As we know from other areas of medicine, when there's a long list of medications, it means that none of them are truly effective. Otherwise, it would eliminate all the others. But some of the medications have indeed been proven in various studies to be effective for pain relief. But mostly what's effective for pain is a matter of time. Time passes, several months go by, and the pain of Peyronie's disease subsides. And you're left with the other issues of curvature and erectile dysfunction. A fracture of the penis, even though it's described as a fracture, because it's not a fracture and there's no bone, of course. A penile fracture is essentially a rupture in the tough outer layer of the erectile bodies of the penis. This is usually caused by, during sexual intercourse, it's essentially a significant trauma or injury to the penis while it's erect. And then what happens is that the blood inside the erectile bodies bursts through the tear in the sheath. The typical story is that during sexual intercourse, there's an unusual snap or pop sound as it ruptures. This occurs when the penis impacts a rigid area, such as the woman's or partner's pelvic region. It's accompanied by pain, an almost immediate loss of erection, and the characteristic sound I described to you. Then, a hematoma gradually appears. A noticeable blood effusion is present. It's called an eggplant deformation. The penis appears with the size, shape, and especially the color of an eggplant. This occurs in certain areas of the world. Particularly in extreme Muslim countries like Iran, it is one of the causes of penile fracture. It's something called takandan. It's a custom that boys are taught to do during prayer. If they experience an involuntary erection, they are supposed to force it down. They try to force the erection down, and sometimes they cause themselves a break in the penis by bending it very forcefully downward. A fracture of the penis is an emergency. It means that if we don't treat this tear and repair it with surgery, it will last for a reasonable period of several hours to a few days. Then irreversible damage will occur. Irreversible damage. It manifests as severe erectile dysfunction. In severe, hard-to-treat curvature, and therefore, this is not always something we can address. Successfully convey this message to people in the community, but when there is significant swelling in the penis, most people will automatically go to the emergency room. Not a few people come in and tell us about such a story, sometimes months or even years later. They come with the complications and tell us a story according to which the details of the story. It sounds like they had a fracture of the penis before we finish. There's a chance we'll call it priapism. It's a condition of prolonged and painful erection. It's very disruptive to having sexual relations, usually these days due to the influence of a severe or overly strong injection into the penis. To achieve an erection, the erection does not want to subside. And once it lasts for several hours, you need to go to the emergency room for treatment. Otherwise, irreversible damage will occur. This can also happen in other circumstances. For example, who am I? The cause for a woman, for instance, from psychiatric medications, there are spinal cord tumors, there are neurological diseases. These neurological diseases can manifest as a loss of reflexes. But today, we almost see every peripheral condition in hospitals. The patient's conditions stem from injections of an autologous substance for the purpose of achieving an erection. So, to summarize, new pain is a warning sign, and it's not part of the sexual experience. There's a similarity here to any pain related to sexual function. We talk all day about pain related to sex. There's a very strong connection between the body and the mind. In some cases, stabilization is involved. Sharp pain can become intense in certain situations. Sometimes the sharp sexual pain requires urgent medical attention. In cases of paraphimosis, priapism, or a fracture of the penis, you need to go to the emergency room. Thank you. Okay. Thank you very much, Dr. Kitre. Questions will be at the end. With your permission, Noam, we will move on to Dr. Rami Ludiansky. He is a senior physician at Hadassah. He is also a specialist in men's health. He will speak with us about chronic pain. Please, greetings to everyone. Can you see the presentation correctly? And can you hear me? Yes, we see and hear you. Great. So, I'm glad to be here for Sexual Pain Awareness Day. Today, I'm speaking about chronic pain. As Dr. Shashini mentioned in the opening, and I'll emphasize again to the community, because it's medical, we are disappointing a significant number of these men at this time. Women who suffer from pelvic pain are receiving, and rightfully so, more and more attention, while the man who suffers from sexual pain remains unseen. If you look at the international diagnostic manuals, you will see this. You will discover something amazing. There is no recognized international definition agreed upon for chronic sexual pain in men. There is no minimum chronicity criterion. What is chronic? After 1 month, after 6 months. And generally, there is no category of sexual pain in men. And we, urologists, call it that. Male dyspareunia, sometimes pain during ejaculation, or chronic prostatitis, and in men, this pain spreads across different definitions, which causes many patients to fall through the cracks. But the truth is, it's an epidemic. Between 2 and 10% of men suffer from chronic pelvic pain. These men report pain around sexual activity, in the groin or pelvis, in the testicles. It actually represents 5. And even say it affects 8% of patients overall who see a urologist. And what about quality of life? The impact? Studies show it's dramatic. And for the quality of life of a person after a heart attack or Crohn's disease, nevertheless, he will see between 4 and 6 doctors before receiving a diagnosis. Here, when we talk about chronic pain during sex in men, we're not talking about one phenomenon. Rather, we're talking about a whole map of sensations and locations. And I will discuss today 3 main conditions we encounter in the clinic. This is chronic pelvic pain syndrome in men. Specifically, this syndrome can include pain during orgasm or pain after ejaculation. A syndrome of patients experience this pain after orgasm. Post-orgasmic syndrome. This syndrome has a fascinating feature. It is less well known. In it, a man feels as if he has the flu immediately after ejaculation. The next thing is pain in the testicles during sexual intercourse. When the pain is focused in the testicles themselves, it intensifies during sexual activity. And finally, there is pain during an erection. This is essentially the situation. It's a less common chronic condition, and it requires first ruling out structural issues like Peyronie's disease, which Dr. Kittray already mentioned previously. The most common situation is a syndrome called chronic pain in the pelvic region. Pain can appear in various locations within the area between the testicles and the anus. It can appear in the groin, in the testicles themselves, or in the genitals. Or it can occur during or after ejaculation. Often, the pain can also be accompanied by additional symptoms, such as a frequent urge to urinate. The urine stream is weak. Sometimes there are also problems with erections or premature ejaculation. And why does this happen? The reasons for this condition are complex. They can include a problem with the pelvic floor muscles. Stress and psychological pressure can also worsen the pain. Anatomical issues and conditions following certain surgeries can also be factors. There may also be increased sensitivity of the nervous system to pain or inflammation, or an immune response in the area. And in some cases, of course, saliva infection as well. So, why do we as doctors make mistakes in diagnosis and treatment? The biggest mistake in medicine is to give antibiotics to every man who has pain in the pelvic area. But the data shows that only 4 or up to 10% of cases are actually bacterial infections. Instead of looking for a bacteria, physicians should operate according to a multidimensional model. As an analogy, the UPONTS model. This model divides the factors into 7 sections. It is a phenotypic model. That is, we are not treating the disease. We are treating its presentation in the patient. In S04 section, it's AU, which is essentially a linear function that deals with issues of variance. If a patient is experiencing difficulty urinating or urgency with urination, complaints that are more typical of an overactive bladder, then we prescribe certain types of medications that can help in these cases. It's psychosocial, appearing as anxiety, depression, or a physical catastrophe of pain like this. It's a negative thought pattern in which the patient interprets their pain in an extreme and threatening way, including thoughts such as, "This pain will never go away. It's probably cancer. No one finds it." Or, for example, "My life is over because of this." And what's the actual physical connection? Research shows a catastrophic thought increase in pain intensity. The body and the brain enter a state of hyperalertness. This causes the nervous system to become more sensitive to every small pain signal. Or is it this? Local inflammation in the prostate, whether infectious or non-infectious. There is no proven infection. Consider a neurological cause with central nervous system sensitivity. Think of it like an amplifier for an electric guitar. The volume is stuck at maximum. And what is the mechanism that, under normal circumstances, the brain uses to filter signals? With central sensitivity, the central nervous system, like the brain or spinal cord, undergoes change. It becomes sensitive, overly sensitive. And signals that wouldn't normally cause pain, such as light touch, do. Or a typical sensation in the pelvis. They are interpreted as severe pain in the brain. Situations like irritable bowel syndrome, fibromyalgia, or migraine. They are relatives of pelvic pain because they share a common mechanism, T. This chapter discusses sensitivity in the pelvic muscles. Basically, the hidden key we will talk about later is what it actually is. They're a sort of cradle of muscles that support the genitals and pelvic organs that control the sphincter muscles. They also participate in sexual function. And what's the connection to pain in many men with chronic pain? These muscles are in a state of excessive tension. The S section is about sexual issues appear as well. In sexual dysfunction, a decrease in sexual function. Pain during ejaculation, a decrease in sexual desire. Here, I want to address my colleagues, gynecologists, and physical therapists, and to say that we need to learn from you. In men, a routine rectal exam is simply not enough. To diagnose pain, a more thorough examination is required. We must perform what is called a clock mapping procedure, a study of the pelvic floor muscles. When a patient complains of pain during urination or ejaculation, this is the clearest sign that their pelvic floor muscles are in a state of excessive contraction. They are not, and they don't know how to relax during ejaculation. During ejaculation, muscles contract rhythmically, and if the muscle is already tense, that contraction it's translated as pain then. In the general examination, we don't just check the prostate. We must look for tenderness at certain time directions. At 1, 11, 9, 3, 7, 5, and 6. And essentially, these are the meeting points with the muscles of the pelvic floor. And tenderness in those locations will be proof that the problem is 375:00:23:44, 597, 00:23:49, 757 muscular, and not due to prostatitis. And they are treatable. It's not part of the medication. He's in pelvic floor physical therapy, and the data shows that the improvement can reach 80% of patients. Now I want to move on to a topic that most of you may not know. Have you heard enough about it? It's a condition called post-orgasmic syndrome. After an orgasm, imagine a patient telling you, "Doctor, after every time I'm with my wife, I feel like I have the flu, fever, runny nose, a muscle pain that can even last a day to 3 days, and it's not psychological." The main hypothesis today is a reaction, an allergic response, likely to an antigen in a man's sperm. So far, today, fewer than 500 cases were recorded worldwide, but I'm sure there are thousands in the public. thousands in the public who aren't listening to this discussion. And what is the treatment, actually? Even though there isn't a consensus yet. Internationally, treatment includes antihistamines and sometimes anti-inflammatory medications, and in certain cases, hormone therapy. Even advanced allergy medications like biologic drugs that work by blocking antibodies. And what about chronic pain in the scrotum? Here, it's very important to differentiate it from pelvic pain. Pain, generally, to pain that is focused solely in the scrotum. And the way, it's usually pain in one testicle that lasts for more than 3 months. And there are 3 sources, but the mechanism is always shared, a nervous mechanism. The first source is idiopathic, that is a kind of chronic sensitivity without a reason. A clear structure. The second is pain after surgery. This can be vasectomy or after hernia repair, or a procedure that caught the nerve. Hernia mesh procedure or by stitch, and sometimes pain comes in weeks, even months after surgery. So the man doesn't always connect the two. And the third source, it's some sort of structural issue. It could be widening of spermatic veins, a condition called varicocele, which could be some sort of cyst in the testicle, or even pain that radiates from lower back pain because of radiculopathy. And here we always operate using a step-by-step approach. First, conservative treatment. That can be very supportive of the testicles. Or anti-inflammatory, or physical therapy, for example. And what's the connection to physical therapy? The testicles and the pelvic floor muscles share the same supply. Nerve supply. Many times, pain that feels like testicular pain is, in fact, pain that is referred from tense muscles in the pelvis. And a man who is experiencing chronic testicular pain tends to unconsciously contract the area. This happens because the contraction is chronic. It creates a trigger point. This trigger point can produce the pain. And it develops a cycle. Essentially, a cycle of pain, contraction, and then more pain. Later, we move on to medication. This is usually neurological medication. For example, gabapentin or amitriptyline. Next, if there's no improvement, it's more interventional. Usually, it's an injection. When a doctor is on call, we inject a local anesthetic. This substance is like lidocaine, directly into the spermatic cord area nearby, to the external inguinal ring. The goal is to temporarily disconnect the nerve communication between the testicle and the brain. The injection is both diagnostic and therapeutic, and often a key to microscopic examination for nerve disconnection later on, if the patient reports a relief of over 50% in pain. While the substance is taking effect, it confirms that the source of the pain is indeed nerve-related and localized. And this is a necessary condition for moving to the next stage. Moving on to nerve disconnection surgeries, what is known as spermatic cord denervation performed with a surgical microscope. It is intended to identify and preserve important vessels, blood, and structures located in the spermatic cord, and the analysis can lead to improvement in 28% of patients, of course, if applicable. For example, if there is a structural problem, such as varicocele, a procedure to tie the veins can be performed. And if it is a residual cyst, a suitable procedure can be performed. To perform a procedure for excision, and in cases, sometimes we even proceed to an orchiectomy removal of the testicle as a final option. This happens when we have tried all the options and they have failed. And what will we be taking home today? It's important to remember that pain during sexual intercourse in men is a common problem. A real and legitimate problem. If you're experiencing pain during ejaculation, in the pelvic area, or around sexual activity, it's important to address it. You are not alone, and you're not to blame, and you don't imagine it. It's not something you should endure in silence. Here are 3 things to remember. First, antibiotics are not always the solution. In most cases, the illnesses are not infectious. The treatment is not always antibiotic. It's not targeted and can even be harmful. A regular checkup with a doctor won't. It's usually sufficient. It's very important to check the pelvic floor. This is often not included in a standard and quite rough examination. And you should always remember that there is treatment available. And understand that there is treatment available. And it's a good idea to start early. The most effective approach is a personalized and multidisciplinary one. It includes medication as well. It also includes pelvic floor physical therapy and treatment, psychological and sexual therapy as needed. And at every stage, we reach out sooner. The chance of success is higher. Thank you very much. Good. Thank you very much, Dr. Ludiansky, for a very, very interesting lecture. I see that there are already questions from the audience. And the first question is, what causes Peyronie's disease? Well, Peyronie's disease, as Dr. Kittray says, is essentially the formation of scar tissue, a tissue in the tunica that wraps around the caverns. There are similar conditions or diseases, such as another disease. This occurs in the hands. It's called Dupuytren's. When it occurs in the feet, it's called leather disease. And essentially, it's a disease caused by an imbalance between the creation of and the breakdown of scar tissue in our bodies. There's a certain balance between scar tissue formation and scar tissue breakdown. When some imbalance occurs, then, essentially, the problem begins. The currently most accepted theory is that it's caused by repeated microscopic injuries. And then the start of an imbalance and the formation of the scar. There are various risk factors, such as diabetes, urethral surgeries, bruises. But it also happens to men without risk factors. The most common ages are in the 50s and 60s. But it also happens to young men. I have patients who are 30 years old and even 20. Also described in boys. Peyronie's disease. And this, and the rate in the population, is around 5% of men. So it's not entirely uncommon. That's regarding the cause of Peyronie's disease. And I think the question is to Dr. Kittray, whether shockwave therapy can help with Peyronie's disease. So, the best answer is it depends on the reason. There are shockwaves. First of all, there are types of shockwaves. There are several studies discussing shockwave therapy as a treatment for Peyronie's disease. They also discuss it as a treatment for plaque. The goal is to improve curvature and alleviate pain. These are shockwave treatments with a different intensity than the shockwaves we use for erectile dysfunction. There are many clinics and treatment centers offering this in the country. So first of all, it's a different type of treatment. It's a completely different intensity. Are there studies on this? They're quite weak, and it doesn't appear in any guidelines. It doesn't appear in any clinical recommendations. It's not something accepted as a treatment in that area. Not for treating the angle, and not for treating pain. And there's a place for it, and a lot of people do it. There's room for treatment because of them to improve blood flow to the penis. The goal is to improve erections and function. Those who are affected as a result from Peyronie's disease. But it needs to be understood that the chances of success are significantly lower than for men who do not have Peyronie's disease. And this is not by choice. It wasn't examined accurately enough in sufficient studies. Therefore, in short, the answer is no. Yes, but it should be said that it specifically relates to pain. There are studies that show improvement in pain. This is a dispute and debate. It doesn't fall within the guidelines. However, if there's already room for shockwave therapy, then it's only for pain at high intensities, not the shockwaves found in machines used for erectile dysfunction. Let's move on to the next question, Dr. Ludiansky. The question was, what is the condition of pain during erection after ejaculation? In other words, as I understand the question, there were sexual relations. And then, on a subsequent attempt, there is pain with an erection. He also writes here, or is a sharp pain that wakes you from sleep. So, do you have any ideas about this? Of course. It could be a part of it. Like the chronic pelvic pain I mentioned, of course, if we're talking about a situation like that. First, we need to rule out any other problems, including an infectious issue, unless it's related to some kind of infection. We need to go through and do the general disease tests. Infectious diseases, chronic inflammation of the genitals, in the prostate, the scrotum, and the testicles. But of course, if we've done all the tests and found nothing, it's usually this. It's related to chronic pelvic pain, as I mentioned. The treatment is always multimodal. It's not some kind of ball, it always goes together. Also medications, pharmaceutical treatment, and often in physical therapy. If I could just add one word, I wanted to. I had them. I've had quite a few patients like that. And it's essentially on the spectrum of prepism, or statric prepism, are people who, despite ejaculating, experience a returning erection that lasts. They want to come down, but can't go to sleep. The erection continues. It's essentially a kind of light prepism. It appears quite a few times. It's a kind of natural inclination they have for this. Very little literature exists on the subject. But from my experience, I treat it as a statric prepism. This flare-up, I try to give everyone local treatment, cold compresses, ice packs, and so on. And if that doesn't work, then it's possible to take Sudafed pills containing pseudoephedrine. With the physical flare-up, I stammer. I've even seen reports of people being given a nasal spray containing Nuolin. They used to treat this with that. In short, that's it. It needs a little time to settle. You need to relax. It needs to be done with relatively simple means, because there are patients, especially young ones, for whom this is really disruptive, and they're unable to go to sleep. That is to say, they are existing. There is sexual intercourse and ejaculation. The erection subsided partially. It returned to being very strong. There is no desire to have further sexual relations, and this really disrupts their ability to go to sleep. I've had several patients like this. It's not common. Yes, so that really can be taken in two directions. One direction is what you mentioned. And it also relates to, there are very rare situations of men who suffer from painful erections at night. That really wakes them up from their sleep. That's exactly the case. There's also this here. The treatment is very, very unclear. You can relax the muscles. Sometimes in combination. Sometimes with an SSRI, sometimes in combination with it. And other relaxants. And the treatment isn't clear. And it's always trial and error with these patients. It's incredibly frustrating, really, really frustrating. It bothers them a lot. Luckily, it wakes them up, right? It's a combination like that of a patient who responded. It's that kind of combination with Valium on the spectrum. Basically, it's the same spectrum of illnesses that they are. I don't know about the question itself. There's a little bit missing. But it could be about additional erectile pain and sexual relations after a first-time experience. And here, there might be some difference between men or couples, where the level of sexual arousal is high. But the body isn't quite ready yet. And the penis is still very sensitive after the previous time. And that can also cause pain. Perhaps the urethra is irritated. I'm a little unclear on the question. It could go in any direction. Okay then, we'll move on to the next question. Dr. Ludiansky, what would a patient with a history of a penis fracture who didn't go straight to the emergency room? What would the complaint be, and what can be done if they didn't seek care during the acute phase? Well, it depends, of course, on how much time has passed since the fracture. Often people come later, after weeks or even years. The swelling is no longer visible and there's no sign of the extreme. But that's what the patient describes. Usually, it's curvature or a significant decrease in erection. And that's essentially two conditions that need to be treated while the patient hasn't arrived on time, of course. We understand that there was at some point an event of a fracture in the penis. And what remains now is the curvature itself, or a boy experiencing significant erections, and here it depends, of course, in an erect state. If the patient, no, he cannot achieve an erection under maximum treatment. So a lot times a solution, even though it's a transplant, a penile prosthesis, and if essentially he still achieves it, he has one. Still has effectiveness under treatment with Viagra or penile injections. So, only curvature can be corrected. We need to say yes a lot to say that we are treating complications. Yes, there is chronic damage here that cannot be corrected at this stage. And we are actually treating the complications of erectile dysfunction and erection problems, just as we would treat any erectile dysfunction or erection problem that comes to us. And, if possible, in both cases there's some kind of combination. There's a spectrum somewhere between a fracture of the penis and microtraumas. These microtraumas cause erectile dysfunction, and immediately, likely many things are somewhere in between. It wasn't a complete tear of the tunica that caused the classic syndrome of a fractured penis with swelling, pain, and the classic story. And there are many people who have Peyronie's disease who, in retrospect, remember some dramatic event a few months before the incident, not like a fracture of the penis. There wasn't swelling many times. They continue to have sexual relations, appearing with a blockage. There wasn't a deviation to the left. There wasn't an immediate loss of erection. But there was trauma to the penis, which was probably a stretch. A partial tear of the tunica with some localized pathological scarring, similar to what you see in scars elsewhere. Excessive scarring in the corpora can then lead to Peyronie's disease. That's essentially the mechanism of Peyronie's disease. And it's important to say, there are also mimics of a penile fracture. That is, sometimes a tear in a superficial vein can cause any rupture to be painful and result in a blood collection. Not in the shape of an eggplant, but a blood collection. And that's a kind of mimic of a penile fracture that actually doesn't cause anything. But it does cause those same damages as a penile fracture, just to a much lesser extent. Scary, right? So, Dr. Kitre, there's a question here. Do you also refer many patients to pelvic floor physical therapy? And if so, typically under what diagnoses? So, I don't think I'm a classic case. I refer a lot of patients to physical therapy. Pelvic floor issues also fall under my area of sexual function, and also under the area of urinary problems. It's a functional logic of urinary incontinence in women and men. I refer frequently for chronic pain, and certainly for urinary disorders. In younger people, there's often pain without a clear anatomical explanation. I refer for many disturbances. I personally experience erectile dysfunction. They haven't yet managed to convince me that pelvic floor physical therapy makes any sense. And to refer for physical therapy. Physical therapy for erectile dysfunction sounds like something that doesn't quite connect. But there are theories. I acknowledge that there are different opinions in this field as well. In the field of chronic pelvic pain and urinary disorders, certainly stemming from an unclear source, there's a very important place. So I agree with you. It needs to be said that the work is also relevant to erectile dysfunction and premature ejaculation, particularly premature ejaculation. The work on these topics is considerably less convincing. There are studies that support it. However, they're far less convincing than studies on chronic pelvic pain, and also on functional urinary disorders. It should be said that there is a lack of awareness, both internationally and in Israel, regarding physical therapy for men. We may be referring many patients, but there are studies/examples. It's still a developing market. As I mentioned in the first lecture, there's still a focus on what is called chronic prostatitis. Antibiotics. And we never consider referring patients for physical therapy. Even though that's the required treatment, it's what's needed. We need to educate both the public and the doctors about this issue, about pelvic floor physical therapy. It's quite impressive. In my opinion, and from my experience, it helps a large number of men, even if it doesn't eliminate all the pain. Relieving some of the pain sometimes requires ongoing maintenance, and repeat treatments, but it's definitely a tool in the widest range. We have that is very, very helpful. Dr. Ludiansky, do you have anything to add about that? Me? I agree. Dr. Kitray, who generally says physical therapy helps with a variety of issues. A pair of disturbances, urination and chronic pain. And what I want to say, the therapist's skill is also very important. Because there are many different kinds of physical therapy that we are less familiar with. But regarding physical therapists, there's also biofeedback. There are other types as well. So, of course, you need to understand that this isn't a treatment that lasts only once or twice. No, it's not something you do for just 2 days and then say you're done. It doesn't work. It's always more than that. These can be treatments in a clinic, and they can also be treatments at home. And it's always an ongoing treatment. Patients who are diligent always come in and say, yes, I do feel some improvement. That's right. So there's also the question of follow-up. Which physical therapists are there for men? Certainly, there are physical therapists available today. Also, and they really specialize in men's pelvic floors. They have experience with men's pelvic floors. And also, a patient came to me and said physical therapy didn't help. So I asked him what they worked with you on, and he tells me they only worked with him on contractions. So that wasn't the physical therapy we intended, because a professor of orthopedics also addressed this. We want to work on relaxation as well. That's the main point. Relaxation and synchronization. For example, in urination, proper synchronization of relaxation and urination. Therefore, you really need a physical therapist, a therapist specializing in this area. This one. And we have one last question, Dr. Ludiansky, another type of pain, hypersensitivity at the tip of the penis that causes a surge of stimulation. Although it's a feeling of pleasure when it's surging, it's painful. Is there a professional name for this problem? And what solutions are there? Generally, what I know. The burning sensation at the tip of the penis is indeed like we talked about chronic prostatitis. But chronic. It's essentially a non-bacterial inflammation of the prostate. Now it's getting worse. This is what I know about chronic pelvic pain. And the treatment is like. We talked about this a lot. Okay, our time is up. I really want to thank both Dr. Kitray and Dr. Ludiansky for the panel, and I'll return the floor. Thank you very much to everyone. Thank you very much. Very, very much.